Hello, everyone. If you hear me, this is Martin Campo from Agitated Solution. Tonight we're going to present, but just before, we're going to wait a couple of seconds, like 15 to 30 seconds, just to let people sign in and get in. We have a lot of attendees tonight, and it's just clicking in, so it's very good. So I'm going to give it another 30 seconds. In the meantime, don't forget, like if you want to address us, it's going to be via the chat box. So, and I'm going to start right away. So good evening, everyone. First of all, thank you for registering and thank you for attending tonight. I'm happy, and not to say very happy, to see so many of you here tonight. As many of you know, I'm working now with Agitated Solutions, and we are introducing the first microbubble generator for the right side heart saline contrast to Canada. In fact, as you know, or if you don't know, you will now. So Canada is the first country in the world to get to use this technology. And that's very interesting because it's very rare that it happened like this for us in Canada. So tonight, we will hear from Dr. Messika-Zeitoun, a cardiologist from Ottawa Heart Institute, and Madeline Jankowski, our clinical educator. They will talk about conducting Valsalva maneuvers in bubble studies, the why, the diagnostic goal, the challenges, and the tip. So following the presentation, you will have time to ask all the questions you may have related to the technique. Just write your question in a question box, and as we go along, we will answer them at the end. Since this is a CME presentation, we will not be able to answer any question regarding sales of the product or pricing. So if you are interested after this presentation to know more information, please, you have my email. Just send me all your questions by email. When you send me your question by email, please identify where you're coming from, or because sometimes some of you are working for different hospitals, different clinics. So I may not remember like where you're from, or sometimes your email may not reflect who you are. So just mention who you are, which clinic you're working for, and what you're looking for as an information. On this, finally, be sure to complete the survey at the end. It is necessary for you to get your CME credits. On this, thank you again, and enjoy this presentation. On this, Madeline, Dr. Messika.
Thank you, Martin. I think I'm starting. If we have the next slide. Next slide, Madeline. Okay. So what I would like to do with you tonight is to give you some key elements regarding the anatomy of the intra-atrial septum and how to assess it in this setting of stroke. You have seen briefly my disclosure slide. So I would like to show you to describe the anatomy of the intra-atrial septum, how to assess a PFO, and why it's important. So during the fetal life, there is a communication between the right atrium and the left atrium based on hemodynamic. At birth, because of change in pressure, you can see that the septum will oppose on the other part, and there is no more communication between the left and the right and the left atrium. Next slide. After that, during life, this foramen oval will close. However, in 25% of the population, the foramen oval can remain patent, especially in some circumstances that we can discuss. For example, if you have a pulmonary embolism, you have an increase in the right atrial pressure, can reopen the PFO. Another important notion is that the rate of patent foramen oval decreases with age. And another key element, and I will show you why it's so important to describe when you assess intra-atrial septum, is the anatomy if the patient has an intra-atrial septum aneurysm. It's usually defined by an excursion of more than 10 millimeters into the right atrium or into the left atrium. There is another possibility that the septum is very mobile and go and prolapse in both directions. But usually the definition is an excursion of 10 millimeters. And here you have two examples. On the left, you have an intra-atrial septum with bombing into the right atrium. And on the right side, you have a very mobile anterolateral septum. And why the PFO is so important? Because it's a cause of stroke in young adults. If you can click on the next one, you have the animation. And so the mechanism for that is a paradoxical embolism. So it can come from the venous system, or it can be in situ in the PFO, and after that going in the left circulation. Next slide. And again, what is very important to remind is that we have some high-risk PFO feature for stroke. The first one is large shunt. The second one is aneurysm, we previously described. The two C and D are less important, but important nevertheless to know. C is a station valve that can direct the flow directly to the PFO and increase the flow and the probability to have a paradoxical embolism. And D is a carry network that can facilitate in situ creation of thrombi that can cross the anterolateral septum and cause stroke. And we have now 6 randomized control trials that have compared the closure with a transcatheter device of the PFO to conservative management using either anticoagulant or antiplatelet agents. But what is key is that if you see in the bottom, that the subset of patients with PFO who benefit the most from the closure are the patient with stroke and high-risk anatomical features, again, large shunt, anterolateral septal aneurysm. In contrast, if you don't have these high-risk features, it seems that closing the PFO, at least in young adult, will not provide any benefit. Next slide. One example here of a high-risk PFO, it's TEE. The left atrium is at the top, right atrium is at the bottom. You can see that the septum is highly mobile, fulfilling the definition of aneurysm, and there is a large shunt from the right to the left. You see that with color Doppler, and also very large shunt with the bubble study. Move. And in our institution, for example, we only do injection in patients that have stroke and are less than 60 years. And so the assessment of anatomy is critical. And regular algorithm to decide if a patient needs a closure of the PFO is based on the ROP score. The ROP score, you have the points on the left side, is telling you what is the probability that the PFO is the cause of the stroke. And so the higher ROP score, the highest is the probability that the stroke is caused by the PFO. And we combine the ROP score with the anatomy of the anterolateral septum. Again, high-risk features, aneurysm, and large shunt. If you have a high ROP score, more than 7, and aneurysm or large shunt, it's very probable that the stroke is due to the PFO. If you have a ROP score less than 7, but still high-risk feature of anterolateral septum, it's possible. In the other situation, it's unlikely. And it's critical to have this algorithm because the patient who get benefit from the closure, if you can click on the box, next, Maddie, another one, are the patient that have possible or probable causality between the stroke and the PFO. In patients that have unlikely causality, it seems that there is no benefit to perform a PFO closure. So for the diagnosis of PFO, the transthoracic, as you know, is a first-line method. We can use the color Doppler, but sensitivity is very low. You need to perform a bubble study, both at rest and during a Valsalva maneuver. It seems quite simple, but it's very important to perform, and that's why we are here today, to perform it very properly and cautiously. So we have transthoracic to diagnose PFO, but we have also TEE and transcranial Doppler. Next one. So the sensitivity and specificity of transthoracic is around 80 to 90%. The sensitivity is probably lower for transthoracic when you have only small shunts. The TEE is usually considered as a reference method. The problem of the TEE is that it's sometimes challenging to perform provocation maneuver when you have the probe inside the mouse. The good thing with TEE is that is proving that the PFO the shunt is due to a PFO. You see the bubble crossing the anterolateral septum, so the definitive proof that it's a PFO. And other information that the TE can provide is to provide anatomical characteristic of the anterolateral septum regarding the funnel and the aneurysm. Transcranial Doppler is another method to diagnose PFO. It's probably the most sensitive. The inconvenience of the transcranial Doppler is that it will not tell you where the shunt is coming from. You see that there is a crossing from right to left, but it doesn't tell you if it's due to a PFO or not. So the principle of a bubble study, it's very simple. You need an IV line. You need to use an agent. Usually we use saline 90% plus 10% air. Some people are adding some blood. And you need a way to generating bubbles. Usually we mix both and we inject, or we can use the Orbis system. So the definition of a positive bubble study is that when you see bubbles crossing the anterolateral septum within 3 beats after injection. You can see here an example of a nice positive bubble study, and you see the bubble getting out from the right atrium to the left atrium through the PFO. And it's not enough to do it at rest. You need to do it during provocation maneuvers. And the most commonly used is the Valsalva. You can do it 2 ways. One is self-directed, which is the most commonly used. You ask the patient to take a deep inspiration to, after that, have a forceful expiration against a closed airway for 10, 15, 20 seconds, and then to release the expiratory effort. It depends on how a patient can follow the recommendation you provide, and the goal-directed is a way to standardize that. Patient is asked to take again a full inspiration and to blow against a mouthpiece connected to a manometer and to maintain the pressure at 40 millimeter mercury for 15 seconds. When you cannot do a Valsalva maneuver, we can do an abdominal compression or ask the patient to cough. They are much lower quality as a provocation maneuver than the Valsalva. And so again, why it's important to perform a Valsalva? Because it's not enough to do a bubble study at rest to diagnose a PFO. If you underdiagnose the PFO, it means that you're going to undertreat your patient, or not, the patient will not benefit the treatment they should have, namely the closure, and patient is exposed to a higher risk of recurrence of stroke. So the Valsalva maneuvers have 4 phases. Phase 1 is onset of straining, when you have an increase of the intrathoracic pressure. Phase 2 is a continuous straining. Phase 3 is a relief of the strain, and phase 4 is a recovery. What is very important, next slide, is to understand what's happening during the release of the strain. When you release the strain, you have a sudden decrease in the intrathoracic pressure. So the blood flow increase from the inferior and superior vena cava into the right atrium, and you increase the pressure inside the right atrium compared to the left atrium. And you can unveil a PFO by increasing the pressure in the right atrium. A good bubble study, 3 parameters. You need to have good quality bubbles, so how you mix, how do you inject. You need to have good image quality, and Maddie will mention and discuss that in detail after. And the timing of injection. Contrast should be injected during the strain phase of the Valsalva maneuver, and strain should be released with microbubble entry into the right atrium. How to assess, especially when you're a reader, if the quality is good? You need to have a full opacification of the right atrium. Ideally, you want to see the septum bombing into the left atrium, and you need to see the shunt within the first 3 beats. One example here of a patient doing a Valsalva. I have highlighted the 4 phases here. So you can see on in the middle of one that you have a nice filling of the right atrium and the right ventricle. In 2, you can see that you have small bubbles coming even at rest. In 3, when you release, you have the bombing of the anterolateral septum, followed by a large flow of bubbles from the right atrium to the left atrium. it's not enough to see it. It's important to do some quantification. And we have seen that indication for closure are aneurysm and large shunt. The definition of a large shunt varied according to studies. Usually it's between 20 and 30 bubbles crossing the PFO during the Valsalva maneuver or at rest. Next. And as always, you have some pitfalls with false positive, false negative. False negative are relatively easy to understand. If your bubble study is poor, you may not see any shunt between the right and the left. Another false negative is that, and that's why we're here again today, if you don't perform a proper Valsalva, if you don't have a nice increase in the right atrial pressure bumping the septum, you might not see the PFO. The false positive are shunts that are not through the PFO, for example, intrapulmonary shunt or anomalous venous shunt. And so in summary, it's important to combine both anatomy, and I told you that presence of anti-atrial septal aneurysm is critical in the management of patients. And you combine that with a bubble study, both at rest and during the Valsalva maneuver. And it's critical to understand, again, that it's a dynamic process. You may not see anything on one day, but if the patient, for example, had an increase in the right atrial pressure due to pulmonary embolism, you can have a reopening of the PFO, and you can see at that time a shunt between the right and the left. And I'm stopping here and pass it over to Maddie.
Great. Thank you so much, Dr. Messika. That was really a great background on especially Valsalva, like understanding the different points of it and when we should be seeing different things in the images. So to go forward with that, I'm going to lead us through more of a sonographer focused presentation just about some technical considerations while we're imaging with Valsalva. So the first thing I want to do is go back over, I think this is one of the things, especially with the self-directed Valsalva, that I know I struggle with in the lab, and it's really how to make the patient understand how we are supposed to do this maneuver and then get the quality maneuver that we need. And so I found this helpful kind of as a visual representation of like over the number of cardiac cycles when you are supposed to be doing each thing. And so as you can see, 1 through 10, so kind of holding that bearing down for 10 seconds, you're going to have the patient do that kind of small inhale to get your image and then bear down. And while they're bearing down, you want to maintain that imaging window. And this is especially important for the bubble study to make sure that you're seeing RA opacification and then seeing the change when the patient releases. As Dr. Messika had mentioned, you'll inject the saline during this strain phase. So kind of in the middle of that Valsalva, probably near like 5-6 beats during, or 5-6 seconds during that Valsalva. Once you inject the saline, it takes maybe a heartbeat or two to get in there, and you should start visualizing that RA opacification. And once the RA is completely opacified, you'll have the patient release. Now, while this is going on, you may also see that shift of the interatrial septum into the left atrium. Remember, we're increasing those right atrial pressures as we're having them bear down. And so sometimes, not in all patients, but you may be able to see that interatrial septum kind of bowing into the left atrium a little more. So this is kind of how I lead a patient through a Valsalva. I like to use very simple explanations. We know that the patients sometimes are very literal and they're taking everything we say with a grain of salt. So I have the patient optimize their breath with the image. I know that every time I say, take a small breath in, they're like, and I lose the whole image. So I'll have them take that image or that breath in to make sure my image is optimized, but then kind of breathing out through their nose. And if sometimes it helps to have them pinch their nose and kind of press against that so they're not actually exhaling, it's just that pressure. And then I instruct them to bear down, and I use the language about like they're having a bowel movement. And I know it's weird and kind of gross, but it usually connects with patients to use that kind of language and to have them do that correct maneuver. Somebody from the Halifax Institute in Dalhousie showed me to put your hand on against their stomach and instruct them to push out against it. So that's really helpful, especially I find in elderly patients who may not have the kind of core strength and they may not understand what to do with their stomach. So that can be helpful to give them a little physical nudge towards that. Again, having them pinch their nose. And then I like to count out loud. It may seem very, remedial and silly, but it helps to kind of make sure that you're getting that full Valsalva done, and then instruct them to hold it. I kind of say 1, 2, 3, keep holding up till 10, and then I will say release. All right, so how to perform a diagnostic Valsalva. So in observing this intraatrial septum shift. So this is just, this is not a bubble study, but this is just a long loop of an apical 4 chamber. And I had this healthy patient bear down, and we can really start to see, even though the septum is not very echogenic and you can't see it very well, we do see the movement kind of. So here he starts bearing down. And then you start to see that the left atrium, now it's kind of starting to bow and making the left atrium cavity a little bit smaller. And then with the release, you'll see kind of a movement of the probe a little bit, and you'll see that heart rate come up slightly. So that's what we're looking for, is kind of that shift. It won't necessarily be like an interatrial septal aneurysm, it won't be that pronounced, but I do think that it does help in patients that you can observe this to make sure that you're doing a good Valsalva. Oops, sorry, go back a second. There we go. So also maintaining an imaging window. So I find that sometimes I'm not using my typical 4-chamber image when I'm doing a Valsalva, just because when they're bearing down, if that image really degrades, sometimes we need to make sure that we are seeing the entire heart while they're bearing down, and then especially when they release. And so sometimes sliding up to a different imaging window, I might slide up a rib space or even slide to a more medial rib space. I'll show you another example in another clip. But this is just the movement of actually sliding up a rib space in this clip. And as you can see, after I slide up, you can still visualize the interatrial septum, maybe not the pulmonary veins as well, but if it is pertinent to get that image all the way through, this can be helpful. Also, subcostal images can be used if there really isn't an apical image. So you can use a 4-chamber subcostal view. Just remember that since the right atrium is on top in those views, you might get a little bit of shadowing from those bubbles. So here are I wanted to pose some challenges just with the settings. So when we're doing a bubble study, there's no need to change the MI or anything like we do in contrast, but I like to sometimes adjust some of my gain and compression settings to really bring out those bubbles. So for gain, I usually use a little bit standard gain settings, but I actually might undergain it a little bit. This is an example of one that seems it's a little slightly overgained. And you can see the bubbles really well, but I tend to, sometimes I decrease the gain just to make sure that I am seeing the bubbles and not necessarily the chordae or something different. So especially with a really bright bubble, that can be helpful. And then compression settings, I will decrease the compression. And this is more of a personal preference than, standardized standard of care. But that decrease in compression makes a more black and white interface. So then it tends to help me delineate those bubbles a little bit better. And then with penetration, using the lowest frequency so that we can really get the best image that we can. And we really don't need to worry about popping the bubbles like we do with an ultrasound enhancing agent. So this image at the top shows a really nice balance of compression, I think a little more decreased compression, so that we're seeing darker blood pools and brighter myocardium. And then those bubbles are really bright when they come in. And this bubble study was a little more poor. I think the gain settings, this is also just a tricky patient, which we all see in our labs. I'm sorry about that. So this has a little bit increased gain and high compression, but it's just sometimes hard to, like, especially before the bubbles are injected, to see that cavity is completely either empty or opacified can sometimes be tricky with the difference.
I think that's so bad that
And then
okay, then I don't remember.
Always. It's like, what's that noise? So sometimes there's some challenges with injecting, with timing of injection. And this is kind of where that schematic came out of when we inject the bubbles and then when to tell them to release, because we really want to make sure to see all those bubbles enter the right atrium in your acquisition to make sure that we can assess the timing well. So in this, even though this was more of a cough study, I'll let this play from the beginning again, but we see there's already full bubbles in the right side of the heart at the beginning of the acquisition. So we're not quite sure how many beats have passed before that was completely opacified. So kind of throwing off that count for the intrapulmonary and cardiac shunting. And then in this one on the right, this is a Valsalva, and they had the patient bear down, but then just with the movement of the probe, I can tell that they had the patient, so there's the release, and then the bubbles came in afterwards. So they had the patient do that really good bearing down, but the timing of the bubbles coming in and the release was a little bit off, so this wouldn't be the most diagnostic Valsalva. And so sometimes we lose the optimized window. I'm sure you guys have all done this when the patient bears down or takes a breath in and you have a lung come over, just like in this picture. So in this study, I'll start this from the beginning again. We have a nice injection and then the patient probably releases, but then we see a nice lung come over. And then once it goes back, we see that there are bubbles in the cavity. And so we didn't quite see the timing of when those came across. So really optimizing that window, that when they bear down, when they're doing all this, you can see the heart and all four chambers throughout that entire cycle. So this is one fix to that, is doing a more medial shot of the LV. So in this bubble study, the sonographer went a little more medial on the patient's chest, kind of tipping that RV up towards the top of the frame. But here we can really see, I'll start it at the beginning again. We have some bubbles that were hanging around from the first injection, and we can see that the intraatrial septum has shifted. And now they had the patient release. So maybe a little bit afterwards, but we were able to see the left atrium and the right atrial opacification throughout that entire bubble study. So another challenge that I tend to get sometimes is just poor bubble opacification or duration of the bubbles. So here we can see a bubble study at rest. And again, sometimes it's the setting, sometimes it's the bubbles. So are they not, are we not agitating it well enough? Are we not, injecting it fast enough? And so then we have a poor opacification of bubbles. So how are we ever going to get them over to the left side if they can barely fill the right side? And so one solution to this is the Orbis microbubble generator, which is now available in Canada. You guys are the first country in the world to have this device available to you, but it makes our bubble studies standardized. And then let me show you some studies about how the bubbles are a little bit better. So we looked at these bubbles compared to standard of care, the manually agitated saline, and we looked at bubble size, peak echogenicity, and duration of echogenicity. And we saw that in all three, Orbis was superior, and in bubble size especially, that we had a very small variation of bubble size, whereas a standard of care had a very large variation. So that may also help help you see the bubbles a little bit more. Peak echogenicity, so how bright were the bubbles? The Orbis was higher than the standard of care. And then also, how long did those bubbles last? So especially when we're doing these maneuvers and trying to distinguish a pulmonary versus intracardiac, we want to make sure those bubbles are hanging out long enough to make sure that they can either cross the septum or we see them coming from the pulmonary veins. And then again, this is just a really nice look at the improved visualization. So we just saw that the peak echogenicity was a lot higher, and then the duration was higher. So in Orbis, we had the peak echogenicity, stayed up really high and was high all the way to about 40 seconds, whereas standard of care died down, right about at starting at 10 and then going down to 15. So in that possibility where we could get that intrapulmonary shunting. So lastly, I just wanted to mention, because this is a Valsalva talk, and there are other ways that we use Valsalva in echo, I just wanted to bring up the question, is Valsalva the same for HCM and for bubble studies? And the answer is yes. So the technique of the maneuver is the same. So kind of having your patient set up that bearing down and maybe that small breath in. But really what I want to bring focus to is that bubble studies focus on the release phase of the Valsalva, making sure that right atrium is opacified before we have them release. And then really important to visualize the heart before, during, and after the maneuver. And I think that's what makes this so challenging. And in HCM, the LVOT gradients that we use Valsalva for can be interrogated during the strain and release phases of Valsalva. So really it's just when we're getting those highest gradients and provoking that obstruction. But in either case, it's very important to have them bear down hard and long. So long for about 10 seconds. So at this point, I guess we will open it up for questions. I see some in the chat here, and we appreciate all of your time. I just wanted to bring up once we are done with questions and everything, there will be a survey that comes up for you on Zoom, and please fill that out so that you can get your CME credit.
You made it. That was excellent. I have a question and comment. So if I understand correctly what you have said, you are repeating the maneuver without injection first. So you are sure that you can track the septum, right and left atrium before injection.
That's correct. Yeah, I also like to give the patients a little practice one before I have them, and maybe I don't do it, I say, give me an 80% Valsalva, or give me kind of 80% bearing down, and also making sure that I can see the image throughout that before I'm starting an injection and doing that part of the study. I want to make sure the patient understands what we're going to be doing. Thanks for asking that.
In your experience, how many people are unable to do a Valsalva? I'm not talking about big strokes, but
yeah. I'd say maybe 60%. I wouldn't say it's not everybody. And I think it definitely depends on the instruction. And then I found age definitely has an effect on it too. Just being able to hold that very long can be challenging for more elderly people.
I have a question as a physician reading echo. how do you notify? So we have seen that in 50% of cases, the physician is in the room, but in many labs, the physician is in the reading room and is not aware about what you are doing with the patient. Is there a way that you can notify, so we can see the bowing or we can see the quality of the injection, but how you can notify physician this is average quality, Valsalva, compare good quality, poor quality, because it has a huge implication, for example, with a young patient with stroke. If the quality is not good enough based on your assessment, maybe we should push for more tests like a TE or a transcranial Doppler. I find that sometimes very frustrating not to know how do you assess quality and how you can tell me.
Yeah, and I find that is, and I'm one of the reasons I'm glad we're having this webinar as a sonographer, and in the I work in the United States for everybody that is on the call here. I'm based in Chicago, and I find that even though we are taught what a Valsalva is, that is not necessarily a part of our day-to-day practice, is assessing the quality of a Valsalva. And so that, you know, having that, being able to tell the physician they weren't, you know, I can tell them if, I think it depends on the sonographer. And I think that practicing and having a better understanding of the physiology behind it may help people assess it a little better.
I was thinking about when I was listening that there is a lot of innovation in simulation. Maybe there is a room for having some simulation here to train sonographers. Maybe. How many injections are you doing for a regular patient with stroke?
In our institution, we'll usually do 3 unless one of them is positive. So we'll do 1 at rest, 1 with a cough, and then 1 with Valsalva.
And if it's highly positive at rest, do you still do Valsalva? Or?
No. Then we'll stop at rest if it is highly positive. If it's an intrapulmonary shunt at rest, depending how large it is, we may do another maneuver to see if there's also an intracardiac shunt. But I think it depends on the size of the intrapulmonary. You know, if it's one of those that fills the ventricle like contrast, then you may not be able to tell with the second injection.
You don't want to be responsible of a stroke as well.
Yes, exactly.
There are a couple more questions in the chat I want to draw your attention to.
Perfect.
So it seems that the bowel movement technique is the most widely used from what we have seen. And one of the questions is, how do you supposed to scan, inject, hold the patient's stomach in the bearing down technique at the same time?
That is you got to grow another arm, I guess. No, no, I think that this, you know, having the patients do the Valsalva, and especially with the belly push or kind of that practice, maybe that's a technique you can do during the practice round of that. And then when you're injecting, but I think that, you know, that may be a time where you have somebody else come in and help, if there's other resources available. But I think that's a challenge when you don't have enough hands.
And you are doing the injection yourself, or you have a second person coming to help you?
In the US right now, since this device is not approved in the US, we have somebody else do it. So we're doing the manually agitated saline, and most often it's a nurse or somebody at the bedside, sometimes another sonographer doing it. So then I'm able to kind of, you know, do, I can kind of at least work the machine and have the belly push, or I can work the machine and if I was doing the Orbis injection, I could do that, but I don't think I could do all 3.
That's what's that. So Ingrid, we don't do everything. You need a second person to inject.
Yeah.
one was how do you assess if the patient is pushing? When I was in France, I was scanning. What I like is to put my elbow on the belly. And so you're scanning and you have the elbow, so you can feel the resistance if the Valsalva is good enough.
I like that. All right, is the right arm IV access adequate for a quality study? Is there flexibility on IV size for existing IV access within patients? I would say for most bubble studies, right arm access is just fine, is adequate, especially if you have a patient that already has an IV in. And I would say the sizes, so the Orbis device fits on any 10 cc saline syringe, and then it will connect to any lure lock. So it doesn't matter the gauge of IV that you have, but for any bubble study, whether standard of care or Orbis, I would suggest at least a 20 or 22 kind of bigger IVs will make sure that the bubbles are passing through there quickly enough. Is there any, and then I guess Dr. Messika, is there any time, I guess in our lab, if we have an indication for like a left SVC or a reason to do a focused left arm bubble study, but is there anything that you would do differently here? Or is there any different techniques you use in your lab for one or the other?
No, we're using the right. One thing to know, sometimes when you inject bubbles, even with the best quality, you don't see opacification, and you have to try the other arm. Sometimes you have some venous malformation in the arm at the axillary level, and the bubble are not coming very well to right atrium. So it's when you inject the best you can and you don't see a lot, I think trying the other arm is important.
Yeah, that's a great point. And I guess, yeah, checking the IV first and obviously see if it's infiltrated. But then if you're able easily, I think I've seen a case like that where they injected the bubbles and we were like, where did they go?
Usually it's a venous malformation.
Okay. So from somebody else, can one Orbis device be used for each injection? For example, do you need to use 3 different devices for rest, cough, and Valsalva? That is suggested to use 1 device per injection. There's a small coating of a surfactant called PS80 that's on the inside, and so that helps to coat the bubbles. It's a very it's found in foods and vaccines and all sorts of things, a very low level of it, but it coats those bubbles and helps the echogenicity a little better. And so to get the full use of that, you would want to do 1 per each injection. But I have seen sites that have done, like pushed a couple of mLs. You just don't want to wash all of that out of there. So my suggestion would be to use 1 for each.
Okay.
Another question from the chat. Liz?
I don't think there are any more questions. The last call for questions. Or maybe we close it.
And you mentioned that, Maddie. I think the rest is also very important to assess the time that you will see for the bubble to reach the right atrium. So you can time a little bit when to inject compared to the strain. If you have a very long IV, you know that.
Yes.
Might be
Yeah.
trouble.
And that definitely depends. That injecting time would depend on how long, if you're using the normal like J loop or a smaller IV tubing or just that little catheter. But if you're using a longer IV extension tubing, that you might inject a little bit earlier so that the bubbles arrive on time.
And we have discussed Valsalva for thoracic, but it's exactly the same principle for TE. Only difference is that the patient has a probe inside, and performing the bearing down can be sometimes challenging. But exactly the same principle in thoracic and TE.
Do you find that you use like an abdominal compression more often in a TEE? I've seen that's used in our site sometimes, just if the patient is, you know, under kind of not as awake.
Yes. We try to combine, and of course we give sedation. So cooperation sometimes is not as optimal as you would like to see with a transthoracic.
Yeah.
Um,
Excellent. Well, thank you all for being here and spending your Tuesday evening with us. We've really enjoyed speaking with you about Valsalva and about bubble studies tonight. And thank you so much, Dr. Messika, for being my co-host tonight. It's been such a pleasure. And again, at the end of this, once we end the webinar, a survey will come up so that you can fill that out and get your CME. And then again, if you have any product or sales questions, you can point them to Martin. So thank you all for your attention.
Thanks everyone, and thanks, Maddie.
All right. Thank you all.